All right, well, thank you everyone for joining the webinar. This is a webinar about HIV Navigation Services, and we're going to be providing just a very brief and general overview. So we'll go ahead and get started by first looking at the history of patient navigation. And on this slide, you'll see a picture of Dr. Freeman, who's kind of considered the father of patient navigation. And so what this slide is saying is that the history of patient navigation within the United States really started with the American Cancer Society report to the nation on cancer regarding cancer with poor individuals in 1989. And in the report, Dr. Harold Freeman states that the American Cancer Society hosted hearings in 7 cities around the country, and the hearings resulted in a report that is the basis of patient navigation. And this really grew around an unmet need, which is access. So let's take a little bit closer look at this study and the report. And the report found 5 critical issues related to cancer and the poor. The 5 critical issues were financial, pain and suffering, sacrifices, fatalism, and cultural sensitivity. So I'm going to go ahead and review each point a little bit more in depth. So we'll start with financial. And with financial, poor people face substantial barriers to obtaining cancer care and often do not seek care if they cannot pay for it. And when I read this, it really made me think about Maslow's hierarchy of needs, which basically is saying that if your most simple and basic needs aren't being met, that you're not going to start thinking about the higher level needs that you have. So if individuals are thinking about where their next meal is going to come from or where are they going to sleep tonight, they're probably not thinking about do they need to go in to get chemotherapy or radiation. So really this is showing that individuals have to prioritize their basic needs of healthcare. If we move on to the next point, pain and suffering, poor people endure greater pain and suffering from cancer than other Americans. And we believe this is related to the fact that there's the financial piece that, if they cannot afford health care, then they're not going to seek it out. We also know that individuals who are poor also have difficulty accessing care until it's absolutely necessary. So they're accessing care later, and as they're being diagnosed in later stages of their illness, then they're experiencing a greater amount of pain, greater amount of suffering. And so this really speaks to how valuable patient navigation can be. And when we think about the continuum of care, how that really is filling in the gaps. That patient navigation can really help fill in the gaps of the continuum of care by helping navigate the client through the healthcare system. And next we look at sacrifices. So poor people and their family often make extraordinary personal sacrifices to obtain and pay for care. And again, this also ties back to the financial piece as well, that if you're not seeking out care until much later in your illness, to the point where you're getting diagnosed with something late, or you're trying to seek treatment for something after you have been experiencing the illness for a long period of time, that the health outcomes aren't going to be as strong. So it's also important to keep in mind that individuals are still underinsured or not insured, even with the Affordable Care Act. And so while individuals might have more access to health care through their insurance coverage, they're still facing barriers. And so individuals still have to think of ways to get to their appointment, to pay for the copays, to pay for their medication. And so it's important to note that just because individuals have coverage doesn't mean that they have access. And so the role of the navigator really is to help with that access in whatever way that might look. And so I think it's also important to note here that it's up to the organization or the way that the services are supported within the state that the navigator would fit into this role of helping with access. So that will vary from state to state, even from organization to organization, of how this will look with the navigator. So fatalism about cancer is prevalent among the poor and may prevent them from seeking care. And so they just, this attitude of what will be, maybe giving up some control over the situation, and maybe they have some less hope about the situation as well. So that attitude really ties into, seeking out care and accessing services as needed. Next slide. Lack of cultural sensitivity. So current cancer education programs are often culturally insensitive and irrelevant to many poor people. And so I just want you all to maybe think about a time that you felt disrespected or misunderstood. And when that happens, did you tend to kind of distance yourself from that situation? So, thinking about if an individual goes to a doctor's appointment, say a trans woman goes to the doctor's appointment, her name is Fran, but she instead is called Billy. And so that's not her name, that's not how she identifies. It's going to be a negative experience, which is going to encourage her to not come back into that clinic to seek out services again because it was a negative experience. So, which also then ties into individuals having a mistrust of providers as well. So those two things going into play can definitely detour somebody from accessing these services. So what did the first patient navigation program look like? So again, Dr. Freeman, who we had the picture of in the beginning, is a cancer surgeon, and he initiated the first patient navigation program with funding from the American Cancer Society. And Dr. Freeman was working at Harlem Hospital at the time in New York, and he observed that primarily poor African American and Latino women were being diagnosed with late-stage breast cancer. And so with that, he saw a need to really address this, why are they being diagnosed in late stage? And so again, tying back to those 5 factors that we discussed earlier, I think kind of lays that out as to some of the reasons why people were being diagnosed with late stage breast cancer. So then we have a patient navigation video that I would like to share with you all, and I think perfect. Thank you.
People who are poor and uninsured in America, irrespective of race, tend to get into the healthcare system late. When those people have cancer and get in too late, they will die. Poverty should not be an offense that is punishable by death. And yet, as things are often, people are punished by death because they're poor. This is a moral and ethical issue for this nation.
Prior to having the Latina nurse navigator, patients fell through the cracks. I didn't feel good about the program. I would go home feeling like, oh my God, what happened to this patient? She didn't come back. How are we going to convey that she needs to come back? Perhaps it's nothing. Perhaps it's something that we need to follow up on. But I didn't feel good about our services.
Well, the greatest need is perhaps our need to educate this particular population. Many times they don't see the significance of pre-testing or pre-screening. Oftentimes they don't see the importance or the significance of follow-up. Some of the tests are just so routine. I mean, women go in for pap smears. We know that we're supposed to have them at certain times, in our lives. And so you go and it's sort of a standard procedure. But if something shows up on that pap smear, that patient needs to be notified. If that patient has no interest, or does not understand the importance of calling back, or as most of the time they're told to do within a 14-day period or 2 weeks, they don't do that. If we don't have addresses or phone numbers to reach them, then those people sort of go without ever knowing that they've had an abnormal screening. So when they come into the clinic, one of the huge things that we have to do is educate them about the importance of the tests and the follow-up.
A few years ago, it was a little bit different than it is today. We did not have access to hardly anything in Eastern Kentucky as far as cancer treatment. We do have that here now, and there are options that people can choose from. But to figure out where they are to navigate that system, it's really hard. And a lot of people say, well, everything's on the internet. We deal with people that don't even have phones in their homes, much less internet. We deal with folks that cannot read or write, that need information. So navigating that healthcare system comes from lessons learned. It's not just getting them into the system. It's how do they get around in that system and what happens to them when they go home.
Because I recommend that home place rural health highly. If I talked all day, I couldn't say enough to tell about how much it helped me, because there wouldn't have been any way that I could have paid for my medicine, and I couldn't get the money anyplace else. I'm for programs like that because there's a lot of people like me, there wouldn't be any way to get medical help that they need. So I believe there should be programs to help everybody.
I think one of the most powerful quotes is from Dr. Freeman in the beginning that says poverty should not be an offense that is punishable by death. And I just think that that's such a strong statement because a lot of times the poor and uninsured are accessing care later on in life, and so, or later on in their disease or illness. And so because of that, we are seeing, you know, that can relate to more pain and suffering or even death. And so it's just, I think it really drives home the importance of how good patient navigation can be and the good that it can do. So thinking about navigation and HIV care and prevention, just some things I would like to kind of tie together is that, you know, HIV positive clients who get into care early are known to have better health outcomes. I think that's no surprise to most of us on the call here. And again, you know, talking about some of the findings from the research that Dr. Freeman had done, you know, we know that sometimes individuals don't get into care right away for a variety of different reasons. And so we think that patient navigation can really help guide patients into care. We also look at the HIV continuum of care, and we know that patients are falling through the cracks in regards to their care or prevention services. And so patient navigation really has an opportunity here to fill those gaps and stop people or prevent people from falling through the cracks. And then it's important to educate people who are living with HIV and those that are high risk for HIV regarding prevention and care, and really driving home the importance of testing, the importance of being adherent to your medication, the importance of going to see your doctor, and why those things are important. So I think that we have a great opportunity here to really start to help individuals that, that are falling through those cracks. All right, so we're going to shift gears here a little bit now, and we're going to talk about the National HIV/AIDS Strategy, which I'll most likely be referring to as NHOS throughout the rest of this webinar. And so for those of you that might not be familiar with what NHOS is, it sets priorities to seek leadership to align all stakeholders towards a common purpose. And so here are a few of the highlights. This was the nation's first ever comprehensive coordinated HIV/AIDS roadmap, and NHOS sets the foundation for broader-based collaboration and engagement with federal and community partners. So NHOS was started, they had goals for 2010, and then they revised the goals just recently, added a fourth goal, and these goals are the goals for 2020. So let's look at what those goals are. And here we see the goals. There are four of them. And the first goal is to reduce new infections, reduce new HIV infections. The second is to increase access to care and improve health outcomes for people living with HIV and AIDS. For three is to reduce HIV health disparities and health inequities. That piece got left off, but it's important to note that we're talking about health disparities and health inequities. And then the fourth goal is to achieve a more coordinated national response to the HIV epidemic. So what I'd like for us to do is to jump in and look at how these goals are tied to the navigator's role. So the navigator's role in reducing new HIV infections for people living with HIV, we talk about assessing what their needs are, looking and seeing what they need, and we'll do that for both people living with HIV and for high-risk individuals. For people living with HIV, linking them to care will be important as well. And then talking about some ongoing support to remain in care will also be important. Navigators will also be able to provide adherence support to their patients. They'll be able to provide referrals to high-impact HIV prevention interventions such as healthy relationships, community promise, couples HIV testing, counseling, and then elicit the client's strengths. We really want to try to instill some self-sufficiency within the clients that patient navigators are seeing, and so really to elicit their strengths helps to build that self-efficacy. For high-risk negative individuals, the way that the navigator can help to reduce new HIV infections is, like I said, assess the need, but also link them to pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and then any sort of HIP interventions such as Mini-Men, Mini-Voices. Community promise would be another example of that as well. And then elicit the client's strengths. Again, that's going to be important that we are able to do that also. For the in-house goal 2, to increase access to care and improve health outcomes for people living with HIV, this isn't really applicable to high-risk negative individuals. Instead, this focuses on people living with HIV. And again, we will want to assess what their needs are. We'll want to link them to care and then help them stay in care. And we'll also want to link them to services that they might need, such as transportation, mental health, substance abuse services, housing support, adherence support. And then also it'll be important to note that we'll be eliciting the client's strengths again to help build that self-efficacy. So for goal 3, again, this goal is to reduce HIV-related health disparities and health inequities. And so what is the navigator's role in that? So navigators traditionally support clients who experience health disparities, and we know from the finding of the report that we mentioned earlier, the 5 critical issues: finance, pain and suffering, sacrifices, fatalism, cultural sensitivity. We know that some of the clients are experiencing these health disparities. And so, navigators can really come in and help address some of those health disparities and inequities. Navigators guide clients through a fragmented healthcare system. And I think about, myself, and when I am making a doctor's appointment, how, I have to either call our appointment line, which sometimes has very long wait lines, or I have to actually take myself into the clinic to go make an appointment. And I'm working in the healthcare setting which I seek my care, so it makes it a little easier for me. But if others have to rely on public transportation, or if they have to take time out of their day just to come down to make an appointment, or if they have to wait for a long time on the appointment line, that's just another barrier for those individuals to seek care. And so navigators can really help guide clients through that. I think about how nice it would be if somebody could make my appointment for me. I give them my information and they can make my appointment for me. That's just one less barrier for me to face when going to get my care. So if individuals are experiencing a lot of health disparities or health inequities, this is a great way for the navigator to help them navigate through the healthcare system. And then navigators also support the individual. Navigators' support of individuals leads to addressing health disparities as a whole. So, this is a great opportunity to take on a more holistic approach. We can look at kind of the broader needs of what our clients, our patients have so we can address those barriers and help them get into care much easier or stay in care. And then the 4th goal is to achieve a more coordinated national response to the HIV epidemic. And again, this will be for both populations, but it really is to establish and maintain cross-organizational relationships to meet the needs of all clients, and to maintain cross-organizational communication to discuss resources, eligibility criteria, and overall client health. So this is where, it's really going to be important for us to, if we're going to start HIV Navigation Services, to build a very strong referral network. That's going to be such a huge piece of the program, because you want to be able to meet the needs of all the clients. And so when that happens, it's likely that your organization won't be able to offer every single thing that the client needs. And so if that's the case, then the strong referral network is going to be very important here. And this is also important to note that this is where you'll start to see MOUs or MOAs being developed between your organization and other organizations to talk about resources and eligibility criteria and how you want your programs to work in conjunction with one another. So in summary, for HNS and INHAS, HIV Navigation Services, as you've seen, can address all 4 goals of INHAS. And HIV Navigation Services can be delivered by staff from community-based organizations, from health departments, and from clinics. And so it's also important to note, because I think there's a lot of concern around this, that HNS is meant to really enhance already existing services. And that's the point that I really want to drive home to you all, that this is really meant to only enhance already existing services. So, some people have, or some organizations have voiced concern around that, but really it's not to take over anything. It's just to kind of add on to what already exists. So I'm going to turn things over to Oscar so we can take a closer look at the HNS model and see how we can tie this all together.
Thank you, Dustin. Just a quick reminder, I'm going to be going briefly over the program stages for HIV Navigation Services. Keep in mind that this is a quick overview and that the CDC will be releasing the national curriculum in the next few months where you can learn more about it in detail. So for the program stages, it's important that we take in mind that, as Dustin just mentioned, this is meant to support current services. And as in previous services, there are different stages that we're going to be going through in order to support the implementation of navigation services. We're going to go through a pre-implementation, implementation, and maintenance. In the case of pre-implementation, it's how the agency is getting ready. First of all, by getting the funding to be able to provide such services and developing an infrastructure that is going to support the implementation of services, along with the rest of the list. The goal of this is that at the end of the day, that the agency has the infrastructure to support such services, because as Dustin just alluded, this is going to be a more comprehensive way of providing services to the clients, where it's not just a single service, but it's rather addressing different needs that a client might have or barriers that a client might be facing that is preventing them from accessing the services. Then we'll go into the implementation, and this is the actual interaction between a navigator and the client, and I'll be talking more in detail about that in a minute. The thing that we don't want to forget is that once all of this has been in place, is how do we conduct the maintenance? And part of it will have to do with conducting the evaluation activities, evaluating the feedback that we're getting back not only from the clients, but also from our funders, and as well as continue to assess and review the program structure, the program capacity, program tools, because this is a service that is ever evolving, and there is going to be a lot of assistance. And just a little parenthesis here to remind you that this is something that you don't have to do alone, that there is a lot of capacity building available at your disposal, and we have many of my colleagues here on the line as well participating in today's webinar. So with that said, as I mentioned, all of this is going to be in place to support the actual implementation of the navigation services. Now, what is it that we want to achieve with this? One of the things that we know is that when we started working 30 years ago in this field, we started creating services to try to support those who were living with HIV and trying to prevent infection from those who were vulnerable to becoming infected with HIV. And we created a series of services that we thought were going to support the clients. Now, one of the things that we started noticing is that folks were not necessarily accessing services as they needed. And part of it had to do with their construct, and part of it had to do also with themselves. So there were different barriers that they were facing. For example, they were facing within themselves, just as some examples, that they had lack of knowledge of the services or how HIV could affect them. There were other issues within themselves, such as fear, substance use, isolation, mental health conditions, and so forth. So this was creating the first layer of barriers. However, this was not all. The client also had to navigate through a series of barriers that were within their environment, such as poverty, poor nutrition, discrimination, lack of housing, lack of transportation, and stigma. Now, all of this combined was making it difficult for clients to access any of the services that were created for them. So this is essentially what we were seeing, that the navigator will come in as the construction worker, as you see there, to break through those barriers and be able to assist the client break through those barriers. With that said, one of the models that we're using to address the needs through navigation services is the social ecological model, which basically explains the interaction that the client has with the different systems, not only within themselves, but also with the interpersonal, with the organization, with the community, and even to the extent of the public policy. So, for example, when we begin with the individual, that's where everything starts, that's where the decisions are made. However, they are also influenced by the interpersonal relations and what are the different creeds or beliefs that a family, friends, or social networks have, and the way that they're socializing. Is HIV, for example, HIV testing, is that something that is promoted within their own social networks, or is it something that they're not talked about, which might hinder and create additional barriers for clients to access those services? At the organizational level, are there different type of services available and readily available where the client will be able to access them, or are there in locations where the client might not be able to reach them? Are the hours even appropriate for the client? If the client works from 8 to 5, are the clinic hours beyond the 5 o'clock time? It is also important to understand that we need also additional community relationships. And this talks about that even though you are going to have a navigator who's going to be supporting the client navigate through the medical system and other prevention services, that it is necessary to create partnerships, professional partnerships, to provide additional support to address other barriers that might be preventing the client from accessing care or prevention services. For example, if a client has to deal with some type of mental health issues, are there any type of mental health agencies that can provide services that will supplement and support the work that a navigator is doing with the client, so that the navigator can focus in working with the client and accessing the pertinent services? And lastly, the public policy. And the way that I like to think about this, and something that you might want to also refer to, is just think about where we would be today if we didn't have the National HIV Strategy that was released in 2010. Where we would be if we didn't have that blueprint that was updated last year, so that we had new goals and emphasis on where the resources were going to be spent and what populations we were going to be focused. Would the direction be different? Most likely, yes. But it is because of this type of policies that a person might be having a greater access to the needed services. Now, let's begin with some of the definitions, and I apologize for the format. I think that they translate wrong with the technologies. But the navigation services are just seen as a guide, guiding individuals to fully access health and prevention services. And this is going to be a comprehensive way in which we are going to be assisting clients. Now, what the navigator role is in this case is that if he or she provides one-on-one hands-on guidance and support to individuals in need of access and to fully engage in HIV prevention and or care services between community and clinical settings. One of the aspects that I'm going to speak about later on is also talking about that we are also going to be working with them on self-sufficiency. And what self-sufficiency means in this case is that the client is going to be aware that navigators is not going to be a permanent role in their lives, but rather that we're going to be working and strengthening their skills and working also with their own strengths, so that the client is able to access the services on their own, even when the navigator is not present. So some of the activities, and Dustin already spoke to this, so I'm not going to spend too much time on this, but these are some of the services that navigators will be presenting to people living with HIV, such as linkage to care and so forth. So as we looked at the services that were provided to people living with HIV, we asked the question, so why is it even important to look at the care continuum anymore? And the answer can be simple, right? It helps us identify where the client is in the spectrum of care services. It also tells us the level of engagement and the need that they might have for additional retention, and also the amount of follow-up needed to support services. So how does this even look in the way that we're going to be working with clients? So for example, we know that about 86% of people who are living with HIV are diagnosed. So we still have a gap here of 14%, right? So we have this area here. Now, the job of a navigator will be to identify those additional folks who need to know their status in order to increase access to care. And as we go down the list, we see the rest of the columns that the numbers begin to be lower and lower. So for example, here we see that people engaged in care, out of everybody who's living with HIV, only 40% are engaged in care. So the role of the navigator is, how do we get from this 86% to this, to increase this 40% so that more people are actually engaged in care? And not only that, but there are going to be activities even within this area and between the gaps between being diagnosed and engaged to care. And that might be addressing additional challenges, for example, transportation, for example, housing, for example, other primary healthcare needs. So the role of the navigator will be essentially to increase this column and also to address the gaps between the different columns. Now, as far as HIV risk-negative individuals, the services that we're going to be providing are going to be very similar to the people who are living with HIV. Things to keep in mind is that obviously there's going to be a high emphasis on high-impact prevention behavioral interventions, housing services, mental health services, as well as PrEP and NPEP, STD screenings, and substance use services. So it will be very similar to the services that we're going to be providing to people living with HIV. And just to give you just a brief overview of this is what the HIV prevention continuum looks like. And it's first of all the testing. It's important that we test folks to identify those who are living with HIV and those who are vulnerable to becoming infected, and how we support those individuals who are vulnerable so that they remain negative, and linking them to prevention services as necessary and as willing and ready as those individuals might be, and making sure that they do stay in those services, as well as their adherence to the different guidelines within each of those prevention services. Now, things to keep in mind with that is that a navigator can be a sounding board, a facilitator to healthcare, a guide, coach, advocate, case finder, resource, someone who teaches the client how to fish. And this is going to be important because we're going to need to draw boundaries, because as part of, as Dustin alluded earlier, this is going to be very comprehensive, and the lines can be blurred with the client. So it is important that we remember that we do not function as a mental health specialist, we do not function as a medical provider, and most importantly, we are not a permanent solution for the client. However, we are going to have different roles. Among the roles, we're going to be working with the clients, working with other colleagues, and working within the community. And when we're working with clients, we want to make sure that we're providing strengths-based support and not deficiency-based support, where it's important that we identify additional resources, such as co-located services, wherever possible. I know that for some of you, you might be working in rural areas where this might be a bit more complicated. So strategizing and identifying the resources that are accessible for clients is going to be important. Also being able to provide individualized, patient-centered navigation services and care, and ensure action planning with monitoring. And this is going to be key in working with the clients, not only in developing the action plan, but developing the action plan in collaboration with the client, and making sure that we are assessing them and supporting them throughout the process of implementation so that we can adjust as appropriate or as the client needs it. And as we do that, we also provide additional support by giving them reminders about their visits or giving them reminders about any other services that they need to access. And when working with colleagues, as a navigator, it will be important to participate in clinical supervision. We know that this is not going to be possible in every setting where navigation services are going to be offered. One of the things that we do encourage, however, is that if clinical supervision is not available, that navigators do seek some type of supervision meeting with with their managers or coordinators so that they can be guided or they can learn how to deal with difficult or with challenging situations. Also, in working with colleagues, being able to seek priority appointments for other services such as mental health services, such as case management, and so forth. And also, we also highly encourage you to participate in multidisciplinary care coordination teams, including case conferencing. And this is where we have different disciplines around the table, such as a medical doctor, case manager, and mental health provider, as well as a dietitian who are working with the same client as you are, so that all of you can share what the client has shared with you, so that you are in a better position as a team and also as a navigator to provide the services that a client needs. Now, within the community, it's going to be important that we build some strong working relationships, because in some of the cases, the community will be referring potential clients to you. But in other cases, it might be important that as a navigator, you also go out there and look for those who might be in need of the navigation services. It is important that we support networking activities as well as develop and maintain rapport and credibility with clients and programs, and also provide referrals as appropriate. And here's where during the training I give the example that in the past I used to work in a clinic where mental health services were not provided necessarily for folks who were negative, and part of it had to do with funding. But one of the collaborations that I formed was with an agency that was providing mental health services just down the street, and they were non-HIV mental health services. But being able to talk about my services and having them talk about their services, we were able to find out that my clients could be referred to them as well as their clients could be referred to me. And we created this relationship where there was this influx of clients for both parts, while at the same time providing support for those clients. And this is just an example of what a professional care team might look like for a particular client. Remember that every single team is going to be looking very different for clients. For example, things to consider is that if a person is HIV positive, that the professional care team might consist of a medical doctor, the disease intervention specialist, the navigator, the case manager, while someone who is negative, their team might be a little bit different, where they might have a HIV testing provider in the team, they might have someone who is providing behavioral interventions, mental health specialists, and so forth. But this is going to be important that we keep in mind as we're working with the different and diverse populations. And one of the things that's going to become very common to all of us is that we are going to be overlapping with the different staff that we're working with different colleagues, that they're going to be providing very similar services as the ones a navigator does. What is important to keep in mind here is that as a navigator, you will be having specific goals to achieve. Every single one of your colleagues have also very specific goals to achieve. So it is going to be important that you remain in constant communication with them as you work with them to work in this overlapping area, to make sure that, listen, if another colleague is supporting your client, for example, in housing needs, then as a navigator, that's something that you don't have to necessarily worry about, but it will be important that you are checking in with your colleagues to make sure that the client is receiving the services that they need, and so forth, and vice versa. Now, let's take a closer look at what the navigation services model actually looks like. One of the things that I would like to remind folks is that I know that not only 151502 funded agencies are in the call. So what we are presenting here is essentially what CDC is recommending for 151502s. It will be important that you check in with your funder and your contract managers to see if they have the same requirements or if the requirements vary in a different way. So for example, people who are eligible for HNS or HIV Navigation Services for CDC funding are people who are living with HIV, are those who are diagnosed with HIV, and those who are not fully engaged in HIV care and treatment. For those who are high-risk HIV negatives, are those who have had a recent HIV negative test and have had any of the following, such as condomless anal intercourse with a partner of unknown or positive status, and have had an STD in the past 6 months, or someone who is actually currently taking PrEP. Once again, please check with your funder to see what is the criteria for eligible clients. I'm not going to go too much into detail about this, but these are some of the services that Dustin went over, and also that the 151502 funding is required. So as a navigator funded under 151502, you're going to be in charge of covering some of this, if not all of these services, when providing HIV navigation services. I know that it's easy to become intimidated by all of these services, but remember, this is why it's going to be important that we remain focused on what the goals are, so that when we are working with other colleagues, we do keep our mind into what are the goals that we need to achieve. And in this case, for people who are living with HIV, is that they remain fully engaged in HIV care and treatment. For those who are high-risk negative, is that they remain fully engaged in HIV and STD prevention services. But in addition to that, one of the goals that they both share is that they also work towards achieving self-sufficiency. And this basically means that clients are able to use care and prevention services on their own. And to break this down even further, self-sufficiency, you can see it as the client is able to identify and resolve the barriers and are able to implement action plans on their own to resolve those barriers. So doing your work with the client is not only going to be, your job is not going to be only to increase access to other services, but it's also going to be important that you work with your client to build their self-sufficiency. And this can be done through different ways, either through building the skills of negotiation, building their self-efficacy, building their self-esteem, or conducting different ways in which they can build their skills so that when you are no longer present as a navigator, they can carry on their own. Now, let's look at the model and what the model entails. The model is composed of 5 different steps. I'm not going to go too much into detail, but I will talk about certain steps here. Now, the first step that you're looking at here is something that we also cover in the program stages, which was the preparation. In the case of the program stages, we focus on preparation being what the agency is going to be doing in order to prepare to implement navigation services. In the case of a navigator, what we're asking them to do is they also have a role in preparing to provide services. In this case, it might be that they are conducting an inventory of resources, meaning checking with their agencies to see what are the different services that they have in-house, and what are some of the different resources that they're going to need to access outside of the agencies. And to doing that, it's going to be important that they're also establishing the professional relationships. In this case, we know that the higher-ups, such as managers, coordinators, or decision makers, you should create some type of memorandum of understanding with other agencies, but a lot of the frontline staff don't play much of a role in that. So what we're suggesting with this is that they go out there and actually meet the people who are providing services, to have a name, so that when they are providing the services to clients and they are referring clients to those agencies, that they actually have a name and a contact that the clients can go and access. The second step talks about recruitment, and recruitment, as I mentioned before, has to do with how a client is brought in. In some cases, the client might be referred to you by other colleagues. In some cases, it might require for you to actually go out there and look for your clients. It is in this step where you're going to also be talking to potential clients about what is HNS, and you're going to be assessing eligibility to the client to see if they qualify for the services, as well as to assess their readiness to engage in navigation services. And speaking of engagement in HNS, this is a step that we think is critical to even before providing actual navigation services. And this is when we're talking about step number 3, engagement in HNS. It is this step where the navigator is working and building the rapport with the client, as well as assessing and resolving barriers of the client to engage in HNS services. So let that sink in for a minute. Assess and resolve barriers for a client to engage in HNS. This is not necessarily to engage in other services, but to what are the barriers that the client might have to work with me as a navigator? Is there anything preventing them? Are my office hours not appropriate for the client? Is my office too far away from where they can access me? Do I need to go somewhere else to actually meet them, to work with them? So it is going to be very important that we take this step serious before we even provide the navigation services. And the last but not last step the last activity in this particular step is establishing expectations and agreements. We want to make sure that the client is aware of what is going to be our role with them, and also what are some of the resources that we can provide, and also as well as our limitations. We don't want to create expectations on the clients that we're not going to be able to meet. Now for this next step, we're going to have step number 4. This is going to be where we are actually conducting the navigation services. This is when we're working with someone who is HIV positive to engage in care or link them to care, or with someone who is negative and we're actually linking them or increasing access to prevention services. And the way we're going to be doing this is, first of all, by accessing barriers to engaging in prevention, care, and social support services that is either going to help a person who's not living with HIV to remain negative, or someone who is living with HIV to have optimal health outcomes. Based on that assessment, we're going to work with the client to develop an action plan so that we can reduce those barriers. And it's important to once again reinstate that it is here that you're going to work with the client to identify what is the client willing to work on, so that when you develop in the action plan, it is something that is realistic and something that the client is willing to work on. And lastly, as a navigator, you're going to be supporting the implementation of this action plan. So this continues to say that you're going to have to assess and reassess this steps, so that if you need to modify the action plan, that you are able to do that and to adapt according to the client needs and to the emerging needs that a client might have. Once again, according to the social ecological model. And the last step here is closing the case. For closing the case, we're going to be conducting the final assessment to see how self-sufficient the client is, how engaged are they in the services that they were supposed to be. In addition to that, is provide final information that is going to support the client remain self-sufficient and remain engaged in services. Now, often the question that comes up here, that has come up in the pilot test, in the pilot training, as well as in other trainings, is how long do we keep a case open, or when is it okay to close the case? And for this case, it is going to be important that you check with your funder to see what are those logistics, or what do those logistics look like for you. So once again, we just wanted to give you a brief intro to what the model is, to what each of the steps look like, and to what the role of the navigator would be. As I mentioned earlier, the CDC, and I want to give a shout out to Rondette Jones, as well as to Chesia Caraway and David Whittier, who have supported the development of this curriculum throughout the way. And they are the ones who are going to be releasing the curriculum in the next few months. I urge you to look at the effectiveinterventions.cdc.gov to look for the schedules of this training. And with this, we conclude this portion of the presentation, and I send it back